Hello and welcome to the ProLongevity podcast. My name is Graham Phillips and I'm the originator of ProLongevity. First and foremost, I'd like to welcome all our new YouTube subscribers who've joined us over the last couple of months. Now, I really hope you enjoy this full-length episode with Professor Aseem Malhotra. We discuss statins, cholesterol, and how lifestyle changes can be the answer to heart disease. Now, do be sure to follow us and Aseem on social media, which are featured in the description. Now sit back, enjoy, and let us know what you think in the comments below. Welcome, Aseem, who I call the Crusading Cardiologist. Aseem needs no introduction from us. There are plenty of YouTube videos. But today we're focusing on Aseem's new book, A Statin-Free Life. And the book covers an awful lot of ground, far more than we're going to cover in one podcast. So I'm going to concentrate on certain very specific aspects. And I tell you, Aseem, the first thing I read right at the forward, I think it's the first few words of the book, is something along the lines of, your genes are not your destiny, or words to that effect. In other words, your genes might load the gun, but it's your lifestyle that fires the gun. And I thought maybe that was as good a place to start as anyone, and let you elaborate on that, and then that'll kind of lead us into the journey of the book.
Absolutely. Thank you, Graham. No, I appreciate that. And that actually, the foreword is written by a very good friend of mine, somebody I admire and respect greatly. He's a cardiologist in Australia called Dr. Ross Walker. And Ross has been sort of on top of this area in terms of cholesterol and statins and the lifestyle management of people with heart disease for a very, very long time. He's got a lot of experience and in some ways has been a mentor to me. So I was really delighted that he wrote the foreword. But to specifically answer that question, it's thought that around up to about 20% of, when it comes to heart disease, and probably related to many chronic diseases, is influenced by your genes, your genetics, and about 80% is environment and lifestyle. And that's what we believe to be true when it comes to heart disease. So that does make sense that it isn't predestined. Of course, some people are at more risk than others. But I think if you do have a family history, then actually, I think it's even more important that you think about how you can best adhere to following the most healthy lifestyle for you, if that's what you want. If you want to have a healthy, long life and not die prematurely from heart disease or have heart attacks, I think that conversation and understanding is very important.
So at the kind of top level, what from your new book, and it'd be related to the answer you've just given me to your last question, what are the key takeaways that when someone's read the book, we're all going to take our individual things from it, but if you were to lay out what are the most important points that you want to make to the world as a crusading cardiologist, what are they?
Well, I think from the book, the three things I would say, Graham, are one, we shouldn't be overly fearful of cholesterol or so-called high cholesterol. So there's obviously a bit of nuance there, which people will read about in the book, and we can discuss a little bit through the podcast. The second thing is that statins the benefits have been grossly exaggerated, even though they're one of the most prescribed drugs in the history of medicine, and that the overwhelming majority of people are not going to benefit from them. And the third most important is that this isn't an anti-statin book, but actually what it's promoting is ethical evidence-based medical practice. And what I mean by that is when it comes to the prescription of statins and when it comes to patients receiving them or being advised to take them, it should be based upon informed consent and understanding what their individual benefit is from the drug, potential harms, and what you do if you get side effects. So I think really the most important, that the first 2 points really lead to the final most important point, is that the book is promoting ethical evidence-based medicine for the purpose of improving patient outcomes.
Which segues really quite nicely. So it's not often I have a tame cardiologist on the podcast. So I'm going to ask some very specific questions, not least because people will be able to watch many other podcasts with you covering other areas. So I'm kind of picking some specifics. And I thought I'd actually start off with what is a heart attack, because I think people generally have a sense of what it is, but I wonder how many people really truly are. I mean, you will, have experienced many of these, So what actually is a heart attack?
So to try and explain it in layman's terms, when I speak to my patients, I always tell them that actually heart attack is cell death of heart muscle, myocardial cell death, if you like, okay? And that most often occurs in a circumstance where there's been a sudden or a sudden blockage in one of the blood vessels that supplies the heart muscle with blood. And that blockage needs to last for long enough, and it has to be usually at least a few minutes before damage to the cells of the heart take place. And the gold standard test for that is something called a troponin. Is a blood test that's carried out usually at least 12 hours after somebody has experienced a potential, a heart attack, to confirm that there's been death of the heart muscle. And of course, you can have a small amount of cell death, a small area of the heart muscle affected, or a very large amount, and that would, in some ways, correlate with the size of the heart attack.
And on the same basis, what's a stroke? Because I think heart attack, I mean, there's obviously many other forms of cardiovascular disease, but the two killers that everyone dreads are the heart attack and the stroke.
Yeah, I think stroke should be synonymous with a brain attack, if you like. So the very similar process going on in the brain where blood supply is usually cut off. It can sometimes also occur from a bleed, but ultimately a stroke is brain cell death. At least, several cells, if you like, losing their ability to function because of lack of oxygen.
So essentially, it's the same process, just playing out in different organs. Is that fair?
It is the same process. The only thing is the risk factors are probably slightly different in the sense of their the hierarchy of what's most important. And I think there's what people, the one thing people need to take away, for the public or patients, is that the single most important risk factor for stroke is high blood pressure. And in fact, that's actually the single most important risk factor for death worldwide is high blood pressure.
Yeah. And we know that we're managing it really badly. I mean, I've done a lot of work in this area, and this is the statistics, at least the latest statistics I'm aware of, Public Health England, that I think 30 to 40% of UK adults have got hypertension.
Yes.
Of whom only 6 in 10 have ever been diagnosed.
Yeah.
But only 2 or 3 in 10 are treated to target. So although we're aware of it, the amount of people where we actually successfully treat it is almost third world outcomes. It's vanishingly low considering how much we're spending on drugs.
Absolutely. On that, Graham, very briefly, I think there are two major issues with the management of blood pressure worldwide, and certainly in this country. The first is that unless you have moderate to severe hypertension, so normal diagnosis of high blood pressure is your average blood pressure is over 140/90, then and moderate is when you get up to 160/100. Unless you're in the category of having over 160/100, the pills aren't really going to improve your outcomes, and they're not going to prevent a heart attack, stroke, or death. Yet probably most people taking blood pressure pills are taking it for the mild hypertension category. So that's one thing that isn't made transparent to patients. And then you're basically taking a pill which doesn't really have any benefit and opens you up to side effects, which is just crazy if you really think about it. While simultaneously not being managed or advised on specific lifestyle changes that can lower your blood pressure. And then, you reduce your risk and you don't need the pill as well. So it's a complete mess. Management of blood pressure is as messy as the management of cholesterol and the use of statins.
No, I completely.
I won't use expletives on the podcast, but in my mind, when I look at it and I think about it, expletives come into my mind quite often, thinking about how we're managing these conditions.
It's absolutely my experience that a lot of my clients come to me with other concerns. And we take their blood pressure, and their blood pressure is extremely poorly controlled. In some cases, I've ended up with urgent referrals because I know that I can bring their blood pressure down over time. But if they're at immediate risk of a stroke or a heart attack, then we need to do something. But as with everything else, the medical system ignores the root cause, or it blames the wrong thing. So I think we'll come back to that as a theme. Now, I want to talk about cholesterol, because you can't really talk about statins without talking about cholesterol. And I think cholesterol gets a bad rap, and I'll be interested to see what your take is. Cholesterol's kind of an evil thing. Well, I would have a different view of that, and I guess you would. So actually, what is cholesterol? What is the thing we're talking about?
So cholesterol has many roles within the body, and including the maintaining the integrity of cell membranes, hormone production. It has been linked to heart disease, although the understanding of it is misguided, and really is only very important if your cholesterol levels are very, very high, where it can be seen as a marker of somebody that can develop heart disease prematurely, rather than necessarily being the cause of it, in my view. And it also has a crucial role to play in the immune system, something I discovered in the last few years. And so without cholesterol, we would die. It's a very important molecule in the body.
And I think that's the fundamental point. 2 million years of evolution, why would that lead us to produce this, that every single cell in the body produces a molecule, a very complex molecule, that's going to kill us? I mean, how does that evolution, either you think evolution is stupid or we're missing a trick here. There is some kind of link between cholesterol. I mean, I think the other important point I always make is there's no such thing as good cholesterol and bad cholesterol. Cholesterol as such is one molecule. Yeah. And I think we conflate the mechanisms that transport the cholesterol, the lipids, and that's where the problems lie with the cholesterol itself.
Yes. Yeah, absolutely. So the LDL cholesterol has been given a bad name because it's found within these so-called plaques, these fatty deposits in the arteries that lead to heart attacks and blockages that interfere with the blood flow when people are doing exercise. Actually, it's more likely, a more plausible explanation is that cholesterol is involved. There's damage to the artery for different processes that go on. Yeah. And then the cholesterol is there to try and help clear that damage or gets deposited, the LDL cholesterol. So as Malcolm Kendrick, a friend of mine in GP, he says just because cholesterol was at the scene of the crime doesn't mean it's the perpetrator.
No, I think
it's like blaming the fireman for the fire.
Precisely that. I'm a big fan of Kendrick, and he always explains things most beautifully. I'm not sure if this is one of his, but he said if you were a Martian and you're looking at the Earth from outer space, and you see lots of death, and you see all these white vans associated, which we call ambulances, you might conclude that the ambulances are the cause of the problem, but actually they're the solution. And the fact that cholesterol is found at the scene of the crime, just as increasingly there's a view that amyloid plaque, which is kind of the cause of dementia, actually isn't the cause of dementia. It's the brain's natural response to other things that are going on. And by attacking the amyloid plaques in the brain, we're missing the point. Actually, that isn't the root cause. We're tackling a proxy. And I think the whole of medicine is kind of fraught with those kind of errors.
Sure, absolutely.
So there's some kind of relationship, not the one that we have been led to believe, but there is some kind of relationship with cholesterol and the way it's transported and cardiovascular disease. So at this point, how do the statins fit into this kind of picture in your view?
I think first and foremost, the way that so I think we need to start from an understanding that 50% of what you learn in medical school will turn out to be outdated or dead wrong within 5 years of your graduation. The trouble is nobody can tell you which halves you have to learn on your own. That was from a quote from Professor David Sackett, who was considered one of the founding fathers of the evidence-based medicine movement. So where have we got to in terms of the evolution of, without going to lots of boring details on where we started, etc. But essentially now it's my own analysis of other people has concluded that really you don't need to start worrying about your cholesterol unless your LDL is certainly greater than 4.9 millimoles per liter, or 189 milligrams per deciliter if you're from the States. That's the units they use over there. And that really is only a very small percentage of people, Graham, that have that level. And then once you get above that level, it doesn't mean you're necessarily going to, have heart disease. There's a strong association there. Most of the people that have that, LDL above 4.9 have something called FH, familial hyperlipidemia, which affects about 1 in 250 people, and genetic condition, you're born with it. But when you go into even detail on those people, about 70% of women and 50% of men will not develop premature heart disease without treatment. Yeah. And then you look at those people, and there isn't any difference in the LDL between the ones that develop heart disease and the ones that don't, and therefore then negates LDL being the cause. There are other things.
So I think that's really important. So I can't remember again who said it, but there's something along the lines of, if your doctor thinks the problem is the cholesterol, they're 30 years out of date. And I think if the doctor thinks that your LDL is the cause, they're 20 years out of date. And if they think it's VLDL, they're 10 years out of date. And if they know about your trigs, they're in date.
Absolutely. So the next question then is, so now we've realized, okay, there is a marker of potential premature heart disease if it's above 4.9. Excuse me, but for everybody else, and even those people with an LDL above 4.9, the question is, does lowering it make any difference? Now, unfortunately, because it was thought to be unethical, and I can understand the mindset here, there's never been any sort of randomized controlled trials showing that lowering LDL in people with familial hyperlipidemia actually improves outcomes. It's just presumed to be the case because it was accepted that that was the cause of the problem. But if you look at all the other data on lowering LDL, and we did a systematic review published in BMJ Evidence-Based Medicine Journal last year, there isn't a clear correlation with lowering LDL and reduction in heart attacks, strokes, and death. So the more you lower the LDL, there isn't a correlation that you have less, risk of heart attack, stroke, or death. And then you look at all the other data, which I write about in the book, and seeing, is there a correlation with LDL cholesterol, for most people and development of heart disease? And on its own, there isn't. Absolutely. So really, it's much ado about nothing, to be honest. I think you should just see your total cholesterol profile as a marker of your risk of heart disease, dependent on other things like your triglycerides and your HDL. So the most important thing, I think, moving on in terms of the evolution of how we prevent and manage heart disease, is looking at your metabolic health markers. And actually, that is synonymous with something called insulin resistance, which is at the root of heart disease and is accepted to be at the root of heart disease. And the 5 things you look at are whether you're pre-diabetic or type 2 diabetic. You can look at something called the HbA1c, your average glucose level, and it should be less than 5.7 ideally. You look at waist circumference. For Caucasian men, less than 102 centimeters is good. And for women, less than 90 centimeters. And then for South Asians, it should be less than 90 centimeters for men and less than 85 for women. Your blood triglyceride levels should be less than 1.7 millimoles per liter, and your HDL should be above 1, so-called good cholesterol. And then finally, you want your blood pressure to be within normal limits. So it should be less than 120/80. Once you go above that, you get pre-hypertension. And really, those are the real factors that we need to look at. But we're concentrating, obviously, cholesterol at the moment. And your triglycerides to HDL are really important when you look at your cholesterol profile in predicting even progression of heart disease. LDL doesn't seem to have much of an effect, really, when you look at data and whether it's a predictor of development or progression of heart disease. And that's really what we need to look at. Now, the reason it doesn't get much of an airing is partly because drug trials that tried to influence HDL and triglycerides didn't really show much benefit. And I think it's because actually the triglyceride and HDL is a surrogate, actually, rather than it being a causal or related to maybe protecting the heart. I think there's a stronger argument to be made that it is a surrogate marker for insulin resistance. And what you're doing is you target insulin resistance through lifestyle, and actually your cholesterol profile will improve and show, indirectly that your risk has reduced.
And exactly right. And it's precisely my experience with my own clients that as we improve their... You were described, I think, in the Daily Mail as a statin denier.
Mail on Sunday. Graham,
was it the Mail on Sunday?
So the reason it's important is I've done a lot of good work with Daily Mail over the years. Completely different editor. People often confuse them. They're completely different editors, different editorial policy. So it was a Mail on Sunday specifically. Yes, absolutely. They accused myself, Malcolm Kendrick, and Zoe Harcum. And in fact, I think an editorial was written saying that a place belongs in hell for people that say statins don't work, which was referencing to us three. But I've never say statins don't work. So it was basically just a nonsense article. In fact, there was a official complaint made to the Press Complaints Commission. I think that's what they're called. But unfortunately, the regulations around what the press do and that kind of stuff is very weak. So you don't really get very far. But, it was it was essentially nonsense, But actually, I took it as a backhanded compliment, really. Because if you're getting attacked in newspapers like the Mail on Sunday, it means you're clearly having an impact. So I was actually pleasantly kind of I was quite pleased, in fact, in a way, indirectly, that was happening, because it means I'm having an impact.
My only regret was that I wasn't named in that article, because, you know, I'm the pharmacist. I'm the pharmacist that gave up drugs.
It's a badge of honor, Graham. Now, isn't it?
Yes.
If you get smeared by the Mail on Sunday, the Daily Mail, then it should be a badge of honor, really.
But I
put it on your CV, actually. It could,
exactly. Yeah. But I think there is a broader
might help
point.
You get honors from the Queen or something like that.
I think there's a broader point here, which is neither of us are actually a statin denier. We've got an issue with statins, which is going to lead on to my next question.
Yeah.
But I don't think either of us would take the position that statins are just never useful and should never be prescribed and be wiped off the face of the earth. So I think we both agree that there is a place for statins.
Yes.
Is that a fair thing
Absolutely.
to say?
Absolutely. This is about the overprescription of a drug, which helps the small minority of people, in particular those with established heart disease, who've had heart attacks. And it's the fact that there is not true informed consent going on when we prescribe these pills to patients. So this is about medical ethics more than anything else.
So there is a percentage of people. I mean, I know that you've written that you do prescribe statins. Now, if you're a complete statin denier, which is a ridiculous cult-like term, you wouldn't do that. And I've just been on the phone to one of my own clients, who's actually he's been talking to Scott Murray, and Scott encouraged him to take a statin. Now, for him, I think there's absolutely every indication. So I just think we need to have a nuanced message here, which is, you know, these things are complicated. There is a place for statins, but what is that place? So,
So Graham, I think the important thing, so in people with established heart disease who've had a heart attack, the absolute individual benefit from taking a statin over a 5-year period, if you trust the industry-sponsored trial data completely. So this is best case scenario.
Absolutely.
Okay. So unlikely to be true, but as close as possible as we can get.
Yeah.
It's 1 in 39 in preventing a non-fatal heart attack, and 1 in 83 in delaying your death or saving your life. But the key thing is you have that conversation with the patient, which is what I do. Now, interestingly, when you look at data on these absolute risk reduction, and you look at other interventions in terms of would a patient choose to take the pill with that level of benefit, about a third of them would say no. And in fact, one case study I wrote up in the Pharmaceutical Journal, which actually became the most read, I think, for the Pharmaceutical Journal that year in 2018, was actually about a patient of mine called Tony Royal, who's a former in Atlantic and suffered a heart attack, and you know, he couldn't fly anymore, so he went back to teaching maths and physics. So he's quite a smart chap and good with numbers. And once he looked at the data himself and understood it, he decided that a statin wasn't for him. He also experienced side effects, but you know, he made an informed decision not to take a statin. And he was someone who had a heart attack, the kind of person that Scott Murray may have encouraged to take the pill. I'm sure Scott would have had an informed discussion with that patient.
Absolutely, yeah.
But so that even for those patients, many of them choose not to take it. I have many patients that choose not to take it, and I always write to the GP or the doctor and saying, well, we've had a fully informed discussion here, and the patient has made a choice and understood what I've said and made a choice not to take a statin, and they should be fully supported in that decision. Unfortunately, what happens, Graham, and I get many patients coming to me for second opinions where a doctor, a GP, but more often than that, either a lipid specialist or a cardiologist has scared them so much to the extent where they've been told if they don't take a statin, they've got a prognosis like someone with terminal cancer, which is complete nonsense. Which is complete nonsense. And then I have to reassure the patient and explain it to them in real terms. I don't think the doctors are deliberately doing this. I think this is basically a lack of knowledge, really. Yeah. It's a lack of understanding, and it's putting too much trust in medical guideline bodies that, unfortunately, as we know, are heavily influenced by the pharmaceutical industry. Yeah. But it's our duty and job, you know, to patients and scientific integrity to do the right thing. So this is really what this book is also about, is trying to encourage people to think a little bit more about what is their role as a doctor, what are they actually trying to do for patients, and what information are they using to make clinical decisions.
I think that's so important. I mean, I have the same experience, which is that a lot of my clients are on a statin, for no particular reason other than the protocol demands it, and the GP, and I'm not criticising my GP colleagues, it's the way the system works.
Yeah, this is a system failure issue. It's not a downstream doctor issue so much. It's a upstream system failure issue, absolutely.
And a lot of them, they've probably seen Ivor, they've seen my interview with Ivor, they've seen things with you, but they're overwhelmed with the sort of hierarchy of the medical profession telling them you have to take a statin or you're going to. And I go through all of this, and I find quite often, having spent half my life, more than half my life, spooning drugs into people, I'm now deprescribing like there's no tomorrow. And what I find is that I send them a couple of presentations. Your book is going to be extremely useful in that regard, and give them the confidence to say, do you know what, actually it's my body, it's my life, and I'm going to make the informed decision not to take a statin, and go back and see their doctor and say so.
Yeah, absolutely.
Now, you've alluded to this, but we haven't dug into the detail, which I do want to dig into. You describe statins as a con in the book. Explain why that is.
Exactly what we've already talked about, Graham, isn't it? The actual benefits are grossly exaggerated. Most people prescribed statins around the world aren't high risk. There isn't a mortality benefit. They're not going to live one day longer from taking a statin in those people that aren't high risk or haven't had a heart attack, and it's not going to prolong their life. So the con is that there is an accepted understanding or belief that it is having all these benefits, and everyone benefits a little, but they don't. And that's basically what the con is. I would go further. I think the cholesterol lowering industry is now at a point, and I said this on GB News last week, it's based upon fraud. Okay. So what is fraud? How do we define fraud? Deliberate deception for the purposes of financial gain.
And I want to make.
I don't think I need to elaborate on that, Graham. I think it speaks for itself.
It does, but I want to go into a bit more into this, because we're dealing here with two matters of medical ethics and matters of scientific principle. Now, if you're a politician, you set up a policy or a procedure or a belief, and you spend your life trying to support it. If you're a science, you set up a theory and you spend your life trying to knock it down. And the whole basis of scientific debate is as follows: that you know, even the theory of gravity, if you wanted to go back and reprove it, you would. And yet somehow there's a sort of statin theory of gravity that's just accepted, and you're not allowed to question it. It's almost heretical to question it.
Yeah.
So that's the basis, the fundamental basis of science, which obviously with my pharmacist scientific training, I understand. Yeah. Another fundamental aspect of science, and particularly clinical trials, is openness of data. In other words, we should be able to access the data as health professionals, the original data that supports the argument that there's evidence behind the use of statins, but that's not the case. And a lot of the data is hidden. So I just wanted to give you the opportunity to say a little bit about more like that, because neither of us are paranoid conspiracy theorists, but this is fact, isn't it?
Yeah, absolutely. So this has been an issue that, as people have, the BMJ, for example, has campaigned to try and get access to that data, which is kept commercially confidential, which is basically most of all of the statin trials. And that's a problem. I think more specifically, rather than the benefits that we've already talked about, the small benefits of statins, it's more about what the true prevalence and rate of side effects are, because that makes a big difference as well.
Yeah.
And that is something that, there's commercial agreements that have been made between the Clinical Trial Service Unit in Oxford University, very influential group of scientists that are responsible for advising on cholesterol lowering and statin treatment, for example, as well as many other drugs. And those agreements that they have with pharmaceutical companies who manufacture the statin drugs. And the analyses that have been carried out by this group, again, are only the data that they've made their analyses on is only privy to those particular scientists. I think the things to add in, which is not to point fingers to say that they're deliberately misleading people, but I think there's a huge bias when you also understand that, or certainly perception of bias, that this particular institution has received hundreds of millions from drug companies that manufacture statins and cholesterol-lowering drugs. So that's a major problem. It's a major issue.
So to be clear, we've got I
think to summarize, Graham, to summarize, we've got the pharmaceutical capture of medical guidelines and medical education.
Yeah.
So if we go to the very root of it, that's where we start from. That dissociation needs to occur so doctors can have better quality, more independent data to make clinical decisions on patients. And this is something that's been creeping up over the years, where we used to have publicly funded research, but most of the research, medical research in this country, is now funded by privately funded, basically from the drug companies. So it doesn't take a rocket scientist to work out that there's going to be a huge bias in favor of the interests of the drug companies here, because they're profit-making businesses.
Yeah.
There's also a legal issue. The law is both, in my view, when it comes to this, is both ethically dubious and undemocratic. Because these businesses, their only obligation is to make profit for their shareholders. They don't have a legal obligation to give you the best treatment. But as I said on GB News again last week, is that the real scandal is that doctors, academic institutions, and medical journals, those with the responsibility to scientific integrity in patients, actually collude with industry for financial gain.
So, I mean, I only learnt this relatively recently, and I should have known it sooner, which is there's this one clinical trials unit, which in Oxford, who have had millions and millions of pounds from the industry, if not hundreds of millions, who have locked away the data, so that people like you and me and anybody else can't actually go and investigate the original data, which shows the benefit or which shows the harm.
Yeah. So we have to just basically trust their word. Yeah, we just have to trust their word, and we call this eminence-based medicine,
Absolutely.
not evidence-based medicine.
I completely agree, and it's also anti-science, which is why I introduced the whole idea of the scientific concept, which is everything is done transparently. You can reproduce it, you can access the data, and you can debate, and yet debate is shut down.
Yeah, so and that reminds me actually of a quote from Einstein: "Is that foolish faith in authority is the worst enemy of truth."
So when you describe it as a con, I don't think you're overreaching, and I don't think it's an unreasonable soundbite. I've independently reached the same conclusion. It's an absolute scandal, because how much harm are we doing? How much good are we doing?
Oh, we've done the harm.
The
harm has affected millions of people over the last 20 years. Graham, the harm is ongoing. Absolutely.
Which brings me neatly to my next question, really, which is, I think lay people have this understandable belief that things are either effective or ineffective, or that they work or they don't, or that they're harmful or that they're beneficial.
Yeah.
But I do think we should try and explain this principle of numbers needed to treat and numbers needed to harm. Do you fancy having a go at that? Because you do cover it in the book.
Yeah, I think it's just a very simple concept, is that first and foremost, I think people need to understand medicine is not an exact science. It's more a practice and art, using probabilities and data to make decisions. The body is very complex, it's dynamic, it's not static. And then when you look at drug trials, which are done to try and show whether a drug benefits, then ultimately in the results it will give you how many people benefited and how many didn't. And that's where you get something called the numbers needed to treat for a single individual to benefit. So for statins in people without heart disease, and this is still based upon industry-sponsored trials, where data has not been independently verified. Absolutely. There's a 1 in 100 chance over a 5-year period, roughly, that you're going to benefit in terms of preventing a heart attack or a non-fatal heart attack or minor stroke, but without a prolongation in life. And that's really what the NNT is. So everybody should really know that. I think with any pill that you're taking, you should ask your doctor, what is the NNT? What is my absolute individual benefit? And that's something that I mentioned in the book. It's really important for people to know that. 1, so they don't exaggerate the benefit in their own minds. 2, so that if they get side effects, stopping the drug isn't going to kill them. And 3, and most importantly, it doesn't distract from other things they can do with their lifestyle, which isn't just going to probably improve their longevity, but also help with their quality of life as well.
So that's numbers needed to treat, and the obverse side of the coin, the flip side of the coin, is numbers needed to harm.
Yes.
And again, we can't access that because we can't access the data.
Yeah, I think if people listening want a better understanding of different interventions, there's a great website which is free open access called thennt.com.
Yeah.
And on that, you can click on various interventions for different conditions, for heart disease, for example, and it will tell you, in terms of what patient input, important outcomes, not pharmaceutical industry important outcomes, but patient important outcomes in terms of what that benefit is. And they also give numbers in the light system about green, overall benefits outweigh the harms. Yellow, it's neither here nor there, and black or red, where actually, no, this is going to cause more harm than good.
And I think what I'm trying to get over to the lay audience is, if I do something or don't do something, what's the likelihood it will benefit me? Or what's the likelihood it will do harm?
Yeah.
Because there's a risk of both. And is there an overwhelming benefit that the good side of it outweighs the bad side? And is it relevant? So not only all of that, if I control my blood pressure but my left arm drops off, that's not a great outcome. So you want to look more broadly, is it going to extend my life, and is it going to extend my quality of life, rather than is it going to control some particular measure of whether it's HbA1c, systolic hypertension, whatever it might be.
Absolutely.
That's not an outcome in my view.
No, absolutely. And I think, Graham, the other thing on this point is to just emphasize for the podcast, for the listeners, that this is not something that is taught in medical school. I'm sure you didn't learn it when you were, studying to be a pharmacist. This NNT concept, it's not something that's taught, and it's certainly not taught that you should be having conversations with patients in these terms. Even though the World Health Organization, 2009, Gerd Gigerenzer, who was the director of the Harding Center for Health Literacy in the Max Planck Institute in Berlin, he said it's an ethical imperative that doctors and patients essentially understand the difference between absolute and relative risk to protect patients from unnecessary anxiety and manipulation. But that hasn't infiltrated into medical practice. The BMJ and the medical Royal Colleges, I was the lead author in a paper in 2015 called Choosing Wisely. The initiative, Academy of Medical Royal Colleges initiative to wind back the harms of too much medicine. And then again, we called for this to be mandated in terms of teaching in medical schools and et cetera, et cetera. So there's still work to be done because it hasn't infiltrated down to the grassroots. And that's another barrier to making the changes happen that are there to improve the quality of care and ethical evidence-based medical practice.
Interestingly enough, it is taught at pharmacy school. We know all about the statistics around clinical trials, NNT and NNH. So next time you have a go at the doctors, please have a go at the pharmacists as well, because we're equally culpable, even more so, because we are taught this stuff, but somehow we forget it. What we do know is that there's an overwhelming growth in cardiovascular disease and all these kind of associated diseases, type 2 diabetes, dementia, etc. So we've talked about what isn't causing it. Let's now talk about what is causing it, and then let's talk about what we can do about that.
Yeah, sure, Graham. So we've just got a few minutes left, haven't we? So at the root of all this problem, I think, is multifactorial from a lifestyle perspective. Poor diet, probably the most important, and ultra processed foods, really foods that are going to interfere with appetite control mechanisms, ones that are going to raise your blood glucose and insulin, so high glycemic index carbohydrates. A lot of those are ultra processed foods anyway. So that, I would say, is at the root cause of the problem, which is driving a lot of these chronic diseases. As well as other things that are important, which I mentioned in the book, is not being sedentary, but also getting enough sleep and reducing your stress levels. But these are societal problems, Graham. So we can do all things individually, but it'll only have a limited impact until you sort the environment out. Actually, if you look at the individual risk factors, control of individual risk factors, through lifestyle changes are very, very limited in terms of long-term benefit until you sort the environment out. It's like asking a child that grows up in a sweets shop to not eat sweets, or asking a woman who's a victim of domestic abuse to just meditate. Yeah. This is really what we're talking about here. So yes, it's important to get the science right for the individual, but it has to also translate into changing environment and structural and policy changes, which means improving the food environment predominantly, and following lessons from how we tackled reduction in cigarettes, taxing cigarettes, public smoking bans, public education campaigns, warning labels on cigarette packages. We should apply the same thing to ultra-processed foods. So the solution is already there, really. If people want to help and improve their health, then they need to get their diet sorted, nutritious foods, home cooked ideally, minimally processed, not be sedentary, and then and reduce their stress levels. So those are the solutions which, again, people want a bit more specific practical advice that is in the book.
And that's kind of you're screwing off again.
Sorry.
Towards the end of the book, you come up with a 28-day plan, which I think addresses all those points. And I just wanted to give the opportunity to say a little bit about that, because this is a book that provides solutions. I mean, a lot of books emphasize the problem, and in the end, you come away completely depressed because all it tells you is that this is not the answer. But I think you've gone beyond that, which is to say that's not the answer that this is. So describe a little bit your program at the end of the book, because I think this is something anyone can do, and it's not an expensive thing to do, and it doesn't involve the use of drugs. Yeah,
so again, it's the diet side, cutting out ultra-processed foods and low-quality carbs. Simple exercise activities, moderate, just walking. You don't need to join the gym actually to get the optimal level of exercise for health, to be honest. 30-minute brisk walk once a day is enough. And then it's thinking about how many hours of good quality sleep are you getting a night. So you should be aiming for at least 7 if you can. And if you're not, then there's an issue, and it will catch up with you, and it will contribute to chronic disease. And often that's linked to the stress levels that people experience. And that's quite subjective. If you're stressed or not. And then there's a specific plan. But the reason it's 28 days, I think, is also to try and help people realize that some of the addictions that they have with these foods can be overcome in 3 to 4 weeks. But also the health improvements in terms of markers actually also occur within 3 to 4 weeks, and there's good clinical data on that as well. So it's also trying to use this, emphasize this concept that food can act like a medicine, obviously a medicine without side effects, but improves the quality of life. In fact, it isn't really medicine, it's better than medicine, isn't it? So that's really why it's a 28-day plan.
Fantastic. So the other thing that I was thinking as I was reading your book is how closely it aligns with what we do within the Prolongevity program, which is lifestyle intervention combined with a continual blood glucose monitor. And what we find is that people think they know what's going to affect them and what's not, but actually on an N=1, on a very individual basis, you get equal and opposite reactions to identical meals. So it's all about facilitating and having the knowledge and the support to move forward with a healthy life. Food, as you say, exercise, sleep, all those things are much more important, and importantly, far more powerful than what we could ever do with the drugs. And that's why I find it so depressing in many ways working in the pharmacies, which I still do, because I just hold my head in my hands and think there's a better way and a cheaper way if anyone knew it.
Yeah, absolutely.
I'm conscious of time, and I know that you need to move on, but I just and I would have liked to discuss the public health collaboration, but perhaps we'll leave that for another day, because that's something.
Yeah, why do we do that? I'd love to speak to you again. I think we could have a long discussion about public health collaboration, because I think the next part of this discussion, Graham, is what we're talking about. How are we going to scale this? So we talk about, the policy changes and stuff. How do we actually contribute to scaling this, to making sure that everybody benefits, not just the, relative minority of people that follow me or follow you, but we want to make sure that everyone benefits from this information, and what changes do we need to do? And I think the public health collaboration certainly is one platform, potentially very influential platform to make those changes happen.
Brilliant. So that could be a sneak preview of our next podcast. It's not a secret that Aseem's just been made the honorary chairman of the Public Health Collaboration. It's an unpaid but substantive role, and when I call Aseem a crusading cardiologist, I think you get the flavour of it. So it would be great to get you, maybe Sam, back on and talk about that and try and broadcast.
That would be fantastic. Yes, absolutely. That would be great. I'd love to do that, Graham.
Aseem, thank you for being so generous with your time. Is there anything else that you'd like to add that I haven't given you the opportunity to say?
No, not at all. I think if people want to just follow my work, or they haven't, they can go to Twitter or Facebook. I also started a crowdfunding, where I do regular blogs and empower people with information on all these different issues through Patreon as well. But no, thank you, Graham. And I look forward to our next discussion.
Brilliant. Thanks for your time, and take care.
All right, mate.
Bye now.
All the best. Bye-bye.